I wonder what she's turning in. Okay.
As well.
Bye. The House Health Policy will come to order. Because Minority Vice Chair Vanderwall is not here wearing his Packers jacket, I thought I would step in and wear my Lions jacket because I think we know the outcome of that recent game. So, channeling my inner rep Vanderwall, we are thinking of you, and I'm sorry you cannot be here to retort, but we will send you the clip of this meeting. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett. Here. Carter.
Yes.
Hadsma. Neely. Here. Glanville. Here. Kapia. Here. Conlon. Conlon.
Conlon. A little louder.
Farhat.
Boyer's here. I'm here.
Fitzgerald.
Here.
Miller. Here. Rangens.
Here.
Vanderwall. Filler.
Yes.
Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Oh, I'm here now. I'm right.
Thompson. Here.
I'm right.
Madam Chair, you have a quorum.
Thank you. Representative Whitsett moves to approve the minutes from our meeting on December 5th, 2024. Seeing no objection, the minutes are approved. Prior to testimony and votes, if you wish to speak or express your position on legislation before us today, please submit a card to the clerk. Sergeants are in the room and will be happy to collect the cards and get them to the committee clerk on your behalf. In the interest of time, you are also welcome to submit written comments to be submitted to the bill record. First up, we will be taking testimony on HB 6046, sponsored by Representative Morse. We will then vote the bill out, followed by taking testimony on SB 542, sponsored by Senator Hertel. We will then vote that bill out, and we will take testimony finally on House Bills 5974, 6152, and 6153, sponsored by myself and Minority Vice Chair Vanderwall. We will then vote each bill out. First up on the agenda, we will be taking testimony on House Bill 6046 to provide Medicaid coverage for community violence prevention services, sponsored by Representative Morse. If you would like to all come up together, that would be great. Most of us, including me, represent districts that are experiencing significant gun violence. Speaking to the bill are Representative Morse, Dr. Brian Stork, a Muskegon-based urologist, youth and firearm injury prevention researcher, and member of the board of the Michigan State Medical Society, and Afonso Harris from the Urban Alliance Kalamazoo. Rep. Morse, the floor is yours, and welcome to Health Policy.
Thank you so much, Chair Rogers, members of the committee. We are very much honored, actually, to bring this legislation before you today for your consideration. House Bill 6046 would allow for the state to obtain Medicaid reimbursement for community violence intervention workers that are both hospital-based and related or working under community orgs. I am chair of DHHS, Appropriations Subcommittee, and in the course of that work, I went across the state and did 6 town halls with my colleagues from the east side of Detroit, Saginaw, Grand Rapids, and in Kalamazoo to talk to members of the community about gun violence and what we need to do to address it. There are so many people like Mr. Harris and Dr. Stork already working in this area, but we wanted to hear from the communities themselves about what they think will help solve, reduce gun violence, because, I mean, of course we would love to solve it, but reducing it is the first step. Far too many people die of gun violence in this state and country. And this came out of that work that people had been doing before the town halls. But what we learned is that there are community workers who are often volunteers doing this work already in the state, who work as mentors or violence interrupters. We have met with people who, if there's a gunshot victim that comes into the hospital, they are assigned, if that victim is willing to talk to someone, to reduce acts of retaliation and also surround that person with the resources they need to recover from the trauma of a gunshot wound. And so there are also members that work out in the community. We have Urban Alliance in Kalamazoo and other areas that Mr. Harris works with, and they are they're called. They work with the police in our instance, not in every city, but certainly in Kalamazoo they do, where if there is some violence that they know is possible of occurring, they send people out into the field. They're basically on call, and they go and respond and try to ensure that violence doesn't actually result in someone with a gunshot wound or other acts of violence. So this is not going to cost a lot for the state. So this is another instance of us obtaining federal Medicaid dollars. So bringing our state dollars, our tax dollars back to our communities to reduce gun violence. And it also provides an outline of how these individuals will be trained, and it directs the department to go through the process of obtaining the funding. So I'm going to turn it over to the people who work in the field so they can talk to you about how important this is. Thank you.
Good morning. Thank you, Chair Rogers, for allowing me to speak today, and thank you for sponsoring the bill. My name is Brian Stork. I am a community urologist, now community violence prevention researcher in Muskegon, Michigan. In 2015, we experienced a very sharp increase in community violence in our Muskegon and Muskegon Heights communities. I was actually called on multiple occasions to our local hospital to care for these patients that suffered significant injuries as a result of this violence. I later found out that one of the patients I took care of had been injured 3 times as a result of firearm injuries. And these were complex cases. They were very labor intensive for the medical staff and for the surgeons, and they were expensive cases to take care of. So today I'm here representing myself, my colleagues on the Trauma Committee, and the Michigan State Medical Society in support of this bill. Seeing this violence, we, as a community of physicians, decided to look into it a little bit further, and we did a research study. We looked at 4 years of charts of community violence victims, and we found that during that 4-year period from 2015 to 2019, that Michigan Medicaid reimbursed our hospital system $4.98 million in the care of these patients. One of the victims alone cost over $250,000 to care for. So in my experience, this is not only, a personal thing with seeing the victim and seeing the suffering that it causes the victims, but I've also seen the suffering it causes the family, our communities, and really the cost associated with providing care for these patients. We were fortunate in that after a community discussion, we were able to partner with the Michigan Youth Violence Prevention Center and get a CDC grant to implement a prevention program called Safer Teens into our community. Safer Teens is a one-on-one intervention that we deliver to youth who come into the emergency room for any reason. So youth age 13 to 21 who come in with a cold or for whatever reason, we screen them for risk factors for committing or being victims of violence, and then we invite them to participate in this intervention. And remarkably, 70% of youth that we invite to participate. We have, over the past 3.5 years, explored delivering this intervention with physicians, resident physicians, social workers, nurses, and clergy. And if any of you have been to an emergency room in the past 5 years, you know that it is a very busy, very dynamic point of care, and that everybody is stressed. And we found that nobody who's currently employed within the emergency room has the bandwidth to deliver this intervention. As a result, we learned about community health workers. Prior to this project, I didn't know anything about community health workers. I learned that they're a bridge between healthcare and our community. I learned that they often come from parts of our community that are most affected by violence. We have seen a dramatic increase in the number of interventions we're able to deliver in the emergency room after moving to a community health worker model. And the model has been so successful that we recently got a grant from the Department of Justice for $300,000 to implement this program into the Muskegon Public Schools, Muskegon Heights, and Orchard View. So we anticipate having 3 community health workers start to deliver these interventions in the school, even further upstream, beginning in January. So as Representative Morris said, the real challenge that we have right now is sustainable funding. This bill would, through working with state Medicaid, provide for sustainable funding for this intervention that we think is not only going to make communities across the state of Michigan safer, but also save Michigan Medicaid quite a bit of money. Thank you for allowing me to testify.
Thank you.
How y'all doing? I'm pushing for the CVI bill to try to create a professional role inside the hospitals that is helping keep the retaliations and other destruction levels going down. Is public information that it costs about $1.7 million for a fatal shooting. From the crime scene cleanup starting at $5,000 all the way through the hospitals, covering $88,525 for gunshot surgeries, all the way down to criminal justice, to incarceration, to victim support, to lost revenue. And we literally out here saving lives. We have data to prove it, but the only thing we can't prove is the murders that we stopped from never happening. How do you get credit for something that never happened? And we realize and understand what other entities that being inside these hospital-based entities and keeping these travesties at bay depleted, we can help transform professionalism inside these hospitals to keep these victims from being suspects. Retaliation is real. Most of the gun violence that's coming out is coming out from retaliation. Having individuals inside of hospitals that you are able to talk to, that you could tell your needs to, that can understand what you're going through, the trauma, the support, the care, on top of what the nurses and everyone else in the institution already, provide, is real. We have real life stories of people who wanted to retaliate and take their life down the path that was headed for destruction, but they didn't, due to our positions inside that, due to our alliances with the public safety that calls us and allows us. We are redefining public safety. You know what I'm saying? That means we are changing the way business was normally done, that people are accustomed to, because a new wave of things is happening here. The violence is high, the gun violence is at an all-time high. So it's important that we discover new ways to drive it down, because we're not here just to make one person safe. We're here to make the whole community safe, so each individual matters. And if we can help transform these settings into safer havens, not just for the person who was hurt, but the people who work there, the crowds and the mobs that report to the hospital. The hospitals have to go on lockdown, literally, to protect everyone else that's in there. If we can get these institutions, or, we can get these facilities on a nice wave of support, I feel like it'll be beneficial for the whole state. Me and my team, as we come out, all we do is what we know how to do. We've been impacted by gun violence on both levels. The CVI has already invested into it. It saves lives, and that's a return worth investing in, and that's the biggest point here. No matter how it comes out, who it comes from, as you can hear from each one of us, we are not with each other throughout our daily lives, yet we have the same journey and we see the same thing. So that should let you know that the picture that is being painted here is real, and we are standing up and we are doing something about it. We're not dependent on one place to be held responsible for it. We as community members are investing in it wholeheartedly, and it's positive. it's supportive, and it's transformative. And transformation takes investment. So I appreciate y'all.
Thank you very much for your powerful testimony. We do have some questions. Representative Filler.
Thank you, Representative, and thank you for coming in and testifying. So I'm just trying to figure out how this exactly works. So if there is any kind of violence, really, if you use the definition, it's just not gun violence, it's literally any kind of violence. Maybe the bill's written that way specifically. But when that happens right now, CVI comes in, or some sort of CVI comes in, and we have, there was a shooting, at a block or something, and you just come in there as volunteers, you get a feel for the situation, and then you encourage either the victim or the perpetrator or whoever involved, families, to then get involved with CVI. So what would change under this is then any following services, who would receive the money? The CVI specifically? Medicaid would then be sending money to CVIs now? Or would it be case by case? I'm just trying to figure out how this actually would work.
Thank you, Rep. Filler. Rep. Morris, would you like to respond and maybe also touch on, so I think I heard how would it work, the type of violence, and then also the funding piece?
In terms of how it's going to work, so we are really, this is not the first state to do this, right? So 8 other states are already doing this. But we are tasking the department with sort of creating the system of exactly how that will work, right? So I'm not exactly sure if the payments are going to go through. They would go through the hospital, right? Because the hospital ostensibly would be paying a staffer or people that are the community workers to be part of their staff. So it's reimbursement to the hospitals for those staffers, is how I understand it. What was the other question? So they're going to be there. So if there is, like, let's say some assault comes in, or there's some other, act of violence that has happened and they're in the ER, then they can be directed to work with that person as well. And it's someone that's trained in how to interrupt violence. And then they also would be aware of, does someone need to be referred to the CCBHC, for example, for mental health treatment, for the trauma, or do they need other social services that the community workers know about as well?
And so if the individual in question, either the perpetrator or the family or a victim involved, does not have insurance of some sort, Medicaid would then pay for the follow-up? Is that how I'm reading it?
The follow-up of what?
Follow-up services given to all these individuals as part of CVI.
Well, if they're already in the Medicaid system, then the Medicaid would be providing whatever
But
Medicaid.
if they don't, then
if they
don't have insurance.
Then they would be referred to Medicaid to see if they're eligible for insurance.
Right. This is about the community violence intervention part. The last question he had that I just would like you to touch on is the type of violence I think he asked about. So if you could explain the type of violence, is it wide open or is it specific?
I'm going to ask Beth Berglund up here,
That's
who
fine.
worked on the legislation.
Welcome to Health Policy, Beth.
Thank you. So the intention of this legislation specifically is to address community violence intervention. It is not intended to address domestic violence, sexual violence. There are already pathways for those things to be billed by Medicaid. It's the services specifically that are delivered in the hospital by the folks that Dr. Stork worked with, Mr. Harris, Ufencio, we call him Big B in Kalamazoo, that B works with in Kalamazoo with his organization, Peace During War, the work that he does with our police department hand in hand to go into the hospital, that is currently unpaid. So he and his team, they go to the hospital and the police don't have funds to pay for that. The hospital doesn't have funds to pay for that. The community has they have grants to come in, but the state is not paying for this public safety service. And so this is the piece where the state CVI office was created within the Department of Health and Human Services. There are grants that have been dedicated to this, but as you all know, this is long-term work that requires permanent funding.
Thank you.
Yeah.
Representative Farhat.
Thank you so much, Chair, and Thank you to Representative Morse for bringing this forward. You know, community violence prevention is kind of one of those things where it's hard to describe, but when you see it in action, it really is able to heal neighborhoods in a way that I think oftentimes state or local government fails to do directly, right? The work that folks like you do is so important in making sure people are safe in their homes, and you break the cycle of violence where it's retaliatory or it's, you know, over maybe an ego. You de-escalate and you bring tools to the table that these neighborhoods need to foster a community place. This is really important legislation that I've seen in my neighborhoods in Detroit, where it's a really good partnership where CVI groups come in. They're able to help diffuse situations, teach de-escalation, break this retaliatory cycle, and they have a good partnership with law enforcement. Michigan's really special in this way. They got a really good, our CVI groups have a really good partnership with law enforcement in the state. So if there is a situation they can't handle, they know how to go to the right professionals to do that. And so I just think it's commendable work. I wanted to highlight that aspect, and that we are in Michigan a leader in the synergies that our CVI groups do. Like these partnerships with the hospitals, with law enforcement, with, you know, the philanthropic partners is so unique to Michigan. In the Detroit area and the Grand Rapids, Kalamazoo area, that I think it's very commendable. It's something that's not uplifted enough. So thank you to the chair, and thank you, Rep. Morse, for bringing this forward.
Thank you. Representative Reinkens.
Thank you, Madam Chair. Sir, I did not catch your name.
Yefencio Harris.
Thank you so much for being here and explaining your role in the process. It sounds like what you serve as is a community health worker, which for my research is not defined in our state's laws and would be defined for the first time in this bill. And this bill technically authorizes payment of people who are then community health workers who go through the training that is then created by the board that is established by this bill. So the funding mechanism, Rep. Filler, is that this bill just allows medical providers to use Medicaid dollars to pay the staff. So that's the mechanism.
So it doesn't
Okay,
go-
hold on. We're not going to have a back and forth. I'm coming back to you. Just a second.
Thanks, Terry.
Hold on.
Chair. So I just want to say thank you for being willing to be a community health worker and for doing this work. It is very important. And I'm excited that we'll be able to define community health worker for the first time in our state laws, because I would love to hear more about that in the future. And this is a great use of folks from the community. So thank you for being here.
Thank you. Next up, we have Representative Carter, followed by Whitsett. Representative Carter.
Thank you, Madam Chair. And I'd like to commend each and every one of you for what you're doing. I'm part of the CVI team in Pontiac, Michigan. And boy, do we have a lot of gun violence in Pontiac. But what we're trying to do is interrupt that cycle. And what I see here with this legislation, I want to thank Councilman Kermit Williams for giving me a poke. And I definitely want to thank Chair Rogers for taking this on. You know, this is great legislation. When you live in a community where you're surrounded by gun violence, you want to do everything you can to mitigate that violence. And this is an opportunity to give the people who know where the nooks and crannies are, know who the people are, maybe be able to interrupt it. Like you said, the retaliation. A lot of gun violence is retaliatory. So if we have the workers in the community where the violence is occurring, then we can hopefully solve it. We don't have to watch 7-year-olds coming home from school gunned down just because. Thank you.
Thank you. Vice Chair Whitsett.
Thank you, Rep. Rogers, Chair Rogers, for bringing this forward. This is definitely something that changes the game in Detroit. I live in an area that is Southfield and 96, if you're familiar. And my area, you hear gunshots every night. And I have a special alert on my phone to let me know what's going on in my neighborhood. And I just had it pop off again where there were 2 gun shootings. And they're like 0.5 from my house. So I definitely commend you for the hard work. Malik Shabazz gets out there and he's in the street and he works hard. And you guys do this with no money because it comes from your heart. So I really encourage my colleagues that's sitting up here to definitely support this. I know a lot of times we don't get things on party lines. And this bill right here needs to be everybody saying yes.
Thank you.
Thank you.
Thank you so much. Representative Thompson, and then I'm coming back to Rep. Filler.
Thank you. I also want to commend you for stepping up and getting into your community and doing something and not just talking about it. But my question is, couldn't this be something that could be funded by the CCHBC? I know that's a big mouthful. Did I get that accurate? Is that something that could be funded through that and people could gain employment and do something similar where you already have a funding source?
Well, I think you would just be taking it out of what it already is. So these programs already exist on a volunteer basis in hospitals. And the CCBHCs are a different organization, right? So, and CCBHCs are outpatient clinics, typically where people go, and maybe the ER refers people to CCBHCs, but it's a separate organization. These people literally are in the hospitals when the victims are brought in and are responding immediately. And so that's really where that's how the system is already set up. And so it serves us better just to go through the hospitals. But I hear what you're saying about, CCBHCs are supported by Medicaid dollars, but this is really just trying to make the best use of Medicaid dollars where the dollars can be most effective.
Can I add a clarification? One of the big things that will happen with this is that DHS, there's a team that would be established so that DHS would define the services that are allowable. The problem is that in no way that we can fund through Medicaid right now are the services that they do allowable in Michigan to be paid by Medicaid. It's federally allowed, 8 other states do it, but we have to create a plan amendment to say these are services that we as Michiganders want to pay for through Medicaid. We just can't, even if you have a CHW, even if you're a surgeon, there's services that aren't billable through Medicaid.
Thank you. Going back to Representative Filler.
Sure. I just want to be clear. So these CVIs are really amazing programs, and I was told about City of Detroit was the first one who I talked to about CVIs. But I guess my confusion at the start of this was this money is going to go to actual CVI employees, like people. So instead of being a volunteer now, you're going to be paid through Medicaid. Is that an accurate read of the situation?
Yeah, their organizations would become billers under Medicaid, like the organizations that they already are affiliated with. So in other states that have done this, they've created, groups of them that are working together, and they get paid through that group, like in the similar way that Medicaid works in other places, where multiple independent contractors would get paid through those billers. Okay. So organizations in Detroit, like Force Detroit, organizations like Urban Alliance in Kalamazoo, we have institutions where this work is being managed through, but it's just not work that is allowed to be billed by Medicaid.
Okay, but it wouldn't just be incident by incident. Like somebody's salary would be paid also. So it's actually both. Is that correct?
I mean, it would be incident by incident because it's a Medicaid. It's like a service that's being billed to Medicaid, just like if you go to the dentist and you need a filling. It's a service that would be paid to your dentist for the service they're providing to you.
Okay.
Thank you.
Thanks,
Seeing no other questions, I'm going to read in the cards of support. City of Kalamazoo, Jim Ritzema, City Manager, supports the bill. Michigan Nurses Association supports the bill. Kalamazoo Department of Public Safety supports the bill. Everytown for Gun Safety supports the bill. Michigan State Medical Society supports the bill. Trinity Health Michigan supports the bill. Michigan Charter Academy of Pediatrics supports the bill. Brady United supports the bill. Citizens for Prison Reform supports the bill. Jermaine Belcher of the Health Alliance of Violence Intervention supports the bill. Dick Camps, MD, supports the bill. Michigan Transformation Collective supports the bill. Family and Children's Services of Kalamazoo supports the bill. Jordan Costa at Giffords supports the bill. Leah Davis, DO, supports the bill. Michigan League for Public Policy supports the bill. Progressive Democratic Women's Caucus of Muskegon County supports the bill. Force Detroit supports the bill. Another Trinity Health, Emma Peterson, supports the bill. Public Policy Manager at YWCA of Kalamazoo supports the bill. Michigan Health and Hospitals Association supports the bill. I just want to quickly say I am supporting this because, like the good doctor mentioned, I have rehabilitated survivors of gun violence. It's a very emotional experience. The entire medical team is affected by it. I still am affected by some of the things I have seen and heard. And I personally, the Little Caesars up the street from my house that my husband stops at weekly when I'm not home for dinner, had gun violence there, and I couldn't get a hold of him. And it really shook me again to my core. So thank you to Rep. Morse for bringing this forward. Thank you to all the testifiers. And will the clerk please, sorry, I got off my script there for a second. Representative Carter moves to report House Bill 6046. Madam Clerk, will you please take the vote?
Chair Rogers.
Yes.
Representatives Witsett,
Yes.
Carter,
Absolutely.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia, Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall, Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Pass.
Schmaltz,
Yes.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 6 pass. The motion prevails.
Thank you, everyone. Now we will be taking testimony on Senate Bill 542, sponsored by Senator Hertel, which would expand the types of dosage of Narcan that the person or agency receive from the Department of Health and Human Services at no cost, so long as it does not jeopardize the DHHS's receipt of federal funding. I believe Matt Black from Senator Hertel's office is here. Thank you so much for joining us. The floor is yours.
Thank you, Chair Rogers, committee members, for the opportunity to testify. As the chair just went over quite a bit of the high points of the bill, I won't take up too much of your time. Basically, this would just allow different entities that use the state naloxone portal. It would require the department to offer all FDA-approved opioid antagonists instead of just the single-dose naloxone that's currently there, and that's really it.
Thank you. Are there questions? Representative Roth.
Thank you, Madam Chair. Probably more of a statement than a question. Sorry. Yeah, I know.
Go ahead.
He doesn't like it, but I'm with you guys on this. This is I've been very disturbed by DHHS not accepting some of the other options. It usually takes 2 of these Narcan doses to. We had 2 officers up in Leelanau County that were subject to that by accident, and yeah, the fact that DHHS doesn't even consider it at this point is silly. So thank you for bringing this forward.
Seeing no other questions, Representative Conlon.
I just wanted to add, thank you, Madam Chair, that I had a firefighter tell me that he had to make a choice between the mother and father, who were both passed out from an overdose, and the child alive in the back seat, a baby, on who to give the 2 doses to, because 1 dose was not going to revive either of the parents, and it was just a horrible story to hear, so thank you.
Thank you for sharing. Representative Glanville moves to report Senate Bill 542. I'm sorry, are there cards? There are cards. Supporting the bill, Fentanyl Fathers. Supporting the bill, Centerline Department of Public Safety. Supporting the bill, Michigan Pharmacists Association. Supporting the bill, Michigan State Medical Society. And supporting the bill, Mental Health Association of Michigan. Now, Representative Glanville moves to report Senate Bill 542 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsett,
Yes.
Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall, Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth, Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. The motion prevails.
Next, we will hear testimony on House Bills 5974, 6152, and 6153, bills to provide licensing for prescribed pediatric extended care or PPEC facilities and payment. Speaking to the bill will be myself. Joining us remotely is Dr. Jody Rogers, director of a PPEC site in Kentucky, Anne Marie Ramsey, faculty member at University of Michigan's Nursing School and nurse practitioner lead for the Pediatric Home Ventilator and Respiratory Support Program at C.S. Mott Children's Hospital, and Tammy Planter, mother of a child with complex medical care needs. Finally, in person, Minority Vice Chair Vanderwaal's legislative aide Nick Miller will also testify, and I'm asking everyone to keep their comments short, including me. The committee will go at ease. Call the chair.
The committee will come back to order. Representative and Chair Rogers, go ahead and you can start when you're ready.
Thank you. I want you to all close your eyes for just a second. Imagine you have just birthed a new baby, your heart is full of joy, and your pediatrician walks into the room to announce that your baby has breathing problems and has been put on a ventilator. After many, many tests, you find out that they have a rare disease similar to cystic fibrosis, and they will be discharged with a tracheotomy and supplemental oxygen requiring 24/7 supervision at all times. Figuring out home care is suddenly filling you with anxiety. There are few options for caring for your newborn who is medically complex, and your regular neighborhood service provider daycare has declined caring for them. You consider private duty nursing, but your child is very isolated and away from their peers. Go ahead and open them back up. Pediatric prescribed extended care facilities, or PPECs, are a solution to add to the menu of options of these types of facilities for families. They are currently licensed and in state statute in 16 other states. The model is like a daycare facility with medical professionals. Included are nurses who are the heartbeat of the care team, rehab specialists, dietitians, social workers, on-site nursing directors, and a medical director who oversees and consults with the team for best care. It is a seamless one-stop shop that can integrate with schools and offer partial day wraparound services. And here on the screen you see a picture of me outside of one of these facilities in Louisville, Kentucky. When I toured this facility in Louisville, which you can see on the screen, we saw children at play painting, laughing, and having fun. There was a area to have activities. This is a commercial kitchen staffed by a dietitian to meet their medically complex special diets, including tube feedings. Here you see a gym and rehab room for physical, occupational, and speech therapy. Here's the kids just laughing and having fun. They also provide transportation, which was something that was added later. You can see it's a wheelchair accessible van. And I was just generally quite impressed. This model can go a long way towards solving some of our workforce issues as well. We've all talked about workforce issues ad nauseum in this committee. And instead of one-on-one care in homes, which is the option most families are utilizing today, generally speaking, this medical daycare facility model provides an alternative with a more dense population. So generally speaking, while it's not prescriptive in the bill, this could be done in rules by the department, but generally speaking, there was a 3-to-1 ratio at most of the facilities that I became familiar with, so 3 children to 1 healthcare provider. These settings have proven to be more successful in helping children meet their developmental milestones and improving social skills. Requirements for licensure include a medical director who is a licensed physician and board certified in pediatrics, a nursing director who oversees day-to-day operations of the PPEC clinic, who must be a registered nurse with at least 2 years of experience. They must provide appropriate staffing and have a staffing plan to determine the ratio that I mentioned earlier, and it's calculated by dividing the total number of nursing hours by the number of patients in the PPEC. complete a functional assessment of the patient to create an individualized plan for the child, and if they are attending school, coordinate with the school, provide or arrange for transportation, submit a $2,000 license fee to LARA, followed by an annual $500 relicensure fee. And in HB 6152 through 3, it sets up a framework for both commercial and Medicaid payments, respectively, for the care that these types of facilities would provide. In other states where PPACs already exist, they tend to save their states money, particularly the Medicaid population, simply by having a concentration. Again, if you're paying for one-on-one care in a home versus a 3-to-1 ratio, it will be cheaper. For House Bill 6154, the Medicaid portion, the annual federal medical assistance percentage, which designates the federal match for state Medicaid expenditures, is 65.13% for the 2024-25 year. Joining me is also Minority Vice Chair Vanderwall's staff, I believe Nick Miller, to discuss the bill, and I'm going to go back up to the front. Thank you.
Thank you, Representative Rogers. The committee will go at ease.
The committee will come back to order. Begin whenever you're ready.
Thank you, Madam Chair and members of the committee. I'm Nick Miller, legislative aide to Representative Vanderwall. The rep sends his regrets that he can't be here to testify, but is grateful that this bill package is being taken up. As you've heard from Chair Rogers and the other speakers, these facilities are going to be life-changing to the kids who will utilize them. Our responsibility as a legislative body is to make sure they can operate effectively within our state's healthcare sector. Part of that is ensuring that those covered by Medicaid have access to these services. That's what 6153 does. Very simply, it ensures that Medicaid covers the utilization of PPECs for eligible families. As we approach the end of this legislative term, I'm optimistic that we can move this package of legislation, and I encourage the committee to vote yes. I'm happy to try and answer any questions.
Thank you so much. The only comment I will say is you didn't wear your Lions gear. Rep Mueller, do you want to ask your question now, or wait till everyone's? Can we wait till everyone's? Yeah. If you want to go back and then come back up for questions, that would be great. Next up, we have Dr. Jody Rogers, from the Director of Nursing at Kids Club in Louisville, which I toured this summer. And because he has such a great last name, I wanted to be sure that he testified in our committee. Welcome to Health Policy.
Thank you for having me, especially Chair Rogers. She came to Louisville, Kentucky, as she said, saw this in action. And again, I'm an everyday nurse named Jody Rogers, and I was kidding and teasing Dr. Rogers. No, we are not related. But I tease her that, I felt confident that a Rogers could deliver this solution to the state of Michigan. And so I was happy with that. But Representative Rogers, I found that really just had a passion for finding solutions for the children of her state, is really where we found the most common ground and relating to pediatric healthcare. And I absolutely wanted to help when asked to for the 10th largest state to adopt this solution as being the 17th state that adopted it as a solution. Prescribed pediatric extended care, which I call PPEC. I've been an advocate for 20 years now. PPEC provides innovative and comprehensive community pediatric healthcare services, and it empowers the lives of children who, with medical complexities. It's a non-residential, child-focused, and family-centered treatment facility prescribed and under the supervision of primary care providers. It's a holistic array of therapeutic interventions and is an important link in the continuum of care, as well as the prevention and promotion and for positive health outcomes outside of the hospital, providing complex care coordination, day health, medical and nursing treatment, developmental interventions, including psychosocial and therapy interventions, nutritional, and most importantly, caregiver training. Children with medical complexities is sometimes hard for the states that I've helped adopt this, for the states to define, stratify, or even target these children. But this vulnerable population includes children usually with chronic medical conditions, usually 2 or more medical conditions that require some level of skilled nursing care or involve subspecialists. That list can include exhaustive cerebral palsy, spina bifida, hemophilia, GI, and metabolic issues. Or these children or infants can have extreme functional limitations. These limitations usually are something that necessitate in high technology dependence. A lot of times we think of ventilators or machines, but just recently I had an argument over extreme functional limitations for a 3-year-old that I had with prosthetic eyeballs, and that conversation with the MCO to say that there was extreme functional limitations was entertaining at least. But these children or infants also have identified case management or healthcare needs. There are multidisciplinary approach that the MCOs can then use this as a tool or solution to uplift the entire family unit by using PPEC. And the fourth thing that really qualifies is that these children having a disparate or elevated healthcare utilization resource costs, and costs alone as a result of their medical conditions can be enormous. And already stated, children with medical complexity, this population comprises fewer than 1% of all children with special healthcare needs, but accounts for 33% or more of total pediatric healthcare costs and expenditures. These children are the highest utilizers of healthcare anywhere. They have the highest rate of readmissions to ICUs or complex care. Their families are at a heightened risk for poor functioning, caregiver stress, burnout, and the lack of community-based resources, programs, or things that can help these families just don't exist. And typically, there's really no out of hospital infrastructure solutions for these families or these children, and the burden then becomes on the family. And this population is increasing really at a conservative rate of 5% per year. This is usually contributed twofold. One being technology and medicines. We're saving more children with cascading problems. So the solutions need to be growing as well. And the other reason it's growing is survivorship is not only saving the children or is contributing to the problem, is that some issues like spina bifida or low birth weight babies is not getting better. In some cases, actually getting worse in non-whites. And so technology and medication can only go so far. We need other outside community solutions. And PPEC does improve the quality of life and access to care while also being a responsible and cost-effective solution. It's shown already that it results in decreased emergency department visits and hospitalizations in the states that it's in. It's shown that even with the plan of care alone that it provides, PPEC serves as a medical home for these children that then does result in positive and measurable outcomes, including improved health-related quality of life, not only for the child, but for the entire family unit, whatever the composition of that, and definitely higher family functioning for them and the scores that they do, especially with compared with other long-term solutions, including private duty nursing and home health. It's 20% the cost of acute care and 65% long-term the cost of other long-term solutions like in-home care. It's a community solution. When I say upstream, I mean that it's catching things as a prevention and promotion long before they happen as a solution that does lift the entire family unit and empowers the lives of these families as well as the children involved. And so the things like the social determinants of health or other things that it uplifts. Most of our children come in hungry, food insecure, their families need the education, they need this sort of service to continue employment or school opportunities, and really this just serves as a safe environment for them.
Thank you so much,
I
Director.
appreciate you allowing me to talk.
Yes, thank you so much, Director Rogers. We appreciate your testimony. Next up, we have Anne Marie Ramsey, nurse practitioner with the University of Michigan. Welcome to Health Policy. Begin whenever you're ready.
Good morning. As Representative Rogers said, I'm Anne Marie Ramsey, and I am a nurse practitioner at CS Mott Children's Hospital in Ann Arbor. And all of these children that you're hearing about right now from Dr. Rogers and Representative Rogers, I take care of. in this hospital. And we have noticed over the last many years that many children get stuck in the hospital. They're not able to go home because there's not enough resources in their communities to help. And this is so important that this issue is being brought up to the members of this community and this committee so that we can begin to address them. Our program here at U of M takes care of over 150 children that are on ventilators with tracheostomies and have chronic medical conditions. We find that this type of care at home is very burdensome on families. And right now in the state, the only support that we have for families is private duty nursing. And private duty nursing is a nurse that comes into the home, paid for generally through the Medicaid program that provides a block of care for children, generally anywhere from 8 to 10 hours. But after the pandemic and onto the future, we have very few of these nurses. This is a scarce resource, and even though families may have insurance approval to have these nurses, they can't get their shift staffed. And so consequently, when you don't have your shift staffed, parents have to assume responsibility for these children. Oftentimes, parents are in a situation where a nurse calls off 10 or 15 minutes before they're supposed to be in the home. And then mom and dad don't have any care. They have to miss work. Sometimes siblings have to miss school because mom can't leave the house to drive them to school. So private duty nursing, where it is a good resource, it is an sometimes undependable resource. And so what we did is come together with other hospitals in Michigan. We have joined with Children's Hospital of Michigan in Detroit, as well as DeVos Hospital in Grand Rapids, and they're experiencing the same things we are. And they're looking to help families to come up with additional solutions in addition to private duty nursing. And so we grouped together and we began inviting other members of the community, nursing agencies, durable medical equipment companies, and we also have family caregivers, and we formed a coalition in 2020 to really start looking at this issue and being very deliberate in developing a plan to come up with a multi-dimensional support systems for families. In looking at this bill, we see that this can be part of this multi-dimensional plan. We would like to also advocate for improving private duty nursing salaries and education. We're also looking at paying parents to potentially care for their child, in addition to looking at other long-term type of care facilities for children. While the coalition's recommendations and House Bill 574 establishes a good framework, it is a good first initiative to address these gaps in care. We envision referring our patients to such centers, and we acknowledge that these measures will take time, but we hope that with continued work together, we can establish this framework. Our coalition remains committed to collaborating with Representative Rogers and other lawmakers who share our priorities. We will continue to serve as a resource to develop comprehensive solutions for our families. By working together, we can ensure that policies are not only practical and effective, but also reflect compassion and urgency to these challenges.
Thank you so much, Ms. Ramsey. We appreciate your testimony. Next up, we have Tammy Planter, a parent of a child with a complex medical care need. Welcome to Health Policy.
Hi, greetings everyone. As you just heard, my name is Tamara Plattner, and I am the proud parent of a medically fragile, severely handicapped child, David Cole Plattner. It is with great enthusiasm that I am presenting a brief history of David's life and how his medical needs have affected not only his life, but that of my entire family. So David was born on April 27th, 2007, with a condition known as arthrogryposis, which presents with many different forms, but for David, this caused contractures in his hands, a left club foot, and dislocation of his shoulders, elbows, and hips with diffuse slow muscle tone. He was also born with a large hernia on his abdomen that required surgery when he was 6 weeks old. Following this surgery, David started to aspirate food into his lungs, which led to a respiratory arrest. Shortly after this, he completed surgery to stop the severe gastric reflux that caused him his aspiration. But after the gastric surgery, he stopped breathing and this was the second time he stopped breathing and required an endotracheal tube to be placed. And then following the endotracheal tube being placed, he had an emergent tracheostomy placed because he stopped breathing again. So following this, the arrest, David had seizures that presented, and he has remained severely cognitively impaired. Today, David is a very handsome young gentleman at the age of 17, trapped in a body that requires nonstop monitoring to maintain his airway by medically trained adults. Due to brain damage that happened after 2 respiratory arrests, David is nonverbal and can only communicate at the level of about a 9-month-old infant, which adds an extra layer of complexity to his care. He is only able to be cared for by myself, his father Kent, and trained nurses. This means that in order for either parent to leave the house, the other parent or a nurse must be present at all times. Most people don't realize that for children with tracheostomies, they can only be transported with 2 people present, one person to drive the vehicle and the other patient to manage the airway. That is what happened with David's care, which limits the ability to take David to events or for leave to help another child if only one person is at home. David has a beautiful older sister, Lori, who has had to manage her entire childhood without knowing for sure that she can attend events.
Ms. Planter, I am so sorry to interrupt, but if you could wrap up in a little last couple sentences, we are pressed for time today. Thank you so much.
So I think the most important thing to know about David's history is that because his airway has to be monitored at all times, we are very limited in what we're able to do, both work-wise and leaving our house. Basically, our house becomes a mini hospital, and we have to make sure that we have care for him nonstop. We have private duty nursing, but it's very limited. And if a nurse calls off or isn't available, we have to call off work ourselves, my husband or I, and of course, not attend events for other children in our home, which is our daughter. The ideas about having a prescribed pediatric extended care facility would be fantastic from the standpoint that we would have a place that would be safe and with medically trained people for David. We have no options at this time to take David any other place than our home or at a hospital if he needs to be monitored for anything. And otherwise, we continue to struggle with the finding of private duty nursing. That remains a real struggle for most families with any type of medically fragile children.
Thank you so much for your testimony. It's very moving and powerful, and we wish David the best, and I hope to get this as another option for you soon. Thanks. I see Representative Farhat has a question.
Yeah, we can do that. I don't know who best to direct the questions to our panel on Zoom. I want to understand how this fits in to the child care regimen or routine of a family, right? Are these like child care centers? Is this like a respite center? How does this fit in for a family who, again, just has a child who needs these services? Are they able to leave them there for prolonged periods? Like, what is how do these help parents?
Sure. So it is a daycare facility. It is during the day, not overnight, and it can be flexible and customizable. So some parents may be part-time workers, and they could do, I've seen a Monday, Wednesday, Friday model to complement the parent's work schedule. It also sometimes coincides with the school year, and so sometimes they will go in the morning before school or after school if the parent is still working, and then go to the school for the school day and then come back to the facility. So it's really flexible. Some children go 5 days a week, Monday through Friday. Some also have Saturdays. So I hope that helps answer your question, Rep. Farhat, but it is pretty flexible and customizable.
It does. And then do we have any in Michigan, any of these types of facilities?
We don't have any PPECs, but there is a similar type of facility in Ypsilanti.
Okay. And that's the only one you're aware of?
Yes, thank you. Representative Thompson.
Thank you, Madam Chair. This is a wonderful idea. And I actually specifically have a question for you because I like how you just said it's flexible, it's customizable. We see this for adults. Why haven't we not come up with this for pediatric patients? So I absolutely love this. But my question about if we can keep it flexible and customizable on the insurance aspect of it, my concern is how come there has to be a mandate for the insurance companies? Is there a way that we could do a more flexible and customizable plan for the insurance companies so that they had the ability to be flexible around their employees and that it wasn't just a one-size-fits-all for the insurance companies?
Thank you for your question. So for the Medicaid portion, again, what I referenced in my testimony is there's a federal medical assistance percentage, and so we can draw off of federal dollars, and that's how I believe the framework is in other states. Dr. Rogers, did you want to chime in at all on the payment piece?
On the payment piece, I was just going to say that it was very similar to what Representative Rogers said as far as the hours, and it's definitely not seen only as a respite service. But the company I work for, have 6 facilities in Kentucky. We have 3 facilities in Florida and 1 facility in Texas. So that's why I always get excited about talking to the new states, which I've helped North Carolina, I've helped Virginia, I've helped other states get this going. I'm excited to help Michigan, but there are some pitfalls that you have to work with the MCOs with, but it definitely needs to be in Medicaid. It needs to be seen as EPSDT. It needs to be seen as prevention and promotion dollars. And the reason I was saying that is because I fought with the MCOs. They were saying, well, there's nothing on paper going wrong with this child. And I said, but they have these extreme functional limitations that is a normalization for them of life. But we've got to be able to address it and throw the kitchen sink at it now because we have measurable outcomes later. But as far as payment, I could give any specific questions.
I think the other thing I'll chime in again is, yeah, so for private pay, for the commercial insurance bill that I have, again, it's actually going to save money because you're having referenced in other states, it's roughly a 3-to-1 ratio. So whereas if you were doing a one-on-one care in the person's home and paying one nurse to care for the child in each person's home, you're having a facility with like that 3-to-1 ratio. So it's roughly a third of the cost. Seeing no other questions, Representative Conlon moves to report card to read in. Michigan Nurses Association supporting HB 5974, 6152, and 6153. Representative Conlon moves to report House Bill 5974. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Yes. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall. Filler. Mueller.
Yes.
Van Workum.
Yes.
Roth. Schmaltz.
Yes.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 5 pass. The motion prevails.
Representative Fitzgerald moves to report House Bill 6152. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall. Filler. Mueller.
Pass.
Van Workum.
Pass.
Roth.
Pass.
Schmaltz.
Pass.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 5 pass. The motion prevails.
We will move to report House Bill 6153. Representative Roth moves to report House Bill 6153. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rangan.
Yes.
Vanderwall. Filler. Mueller.
Pass.
Van Workum.
Pass.
Roth.
Pass. Pass.
Schmaltz.
Pass.
Thompson.
Pass.
Madam Chair, you have 12 yeas, 0 nays, 5 pass. The motion prevails.
Representative Miller moves to excuse absent members. There being no objection, the motion prevails by unanimous consent. It has been the honor and privilege of my career to chair House Health Policy Committee. I have tried my best to be fair and hear all sides, whether I agreed with you or not. I am proud many of our bipartisan bills have been voted out of this committee this past term, including Filter First legislation, maternal health, occupational and physical therapy compacts, health data utility bills, and many more. Many have asked me what I intend to do my next term after I likely will no longer hold this gavel. But my response is simple. I will continue to work in a bipartisan manner whenever possible to improve the lives, safety, and access to health care for Michiganders. Thank you to each and every member on this committee and stakeholder and resident for your input with us this process this term. You are very much appreciated, and I feel really positive about what we have accomplished together. Thank you, Clerk Sweet, for being literally my right hand, Coffee Ann for literally being my left hand, and my staff, Raleigh and Logan, for all of your hard work. There being no further business before the committee will stand adjourned.